Hi, this is Dr. Lani Simpson, and tonight we have a special guest, Dr. Robert Purchase. He is a doctor from San Francisco who specializes, wait, let me pull it up here. He's an orthopedic surgeon in San Francisco, and he specializes in surgery of the shoulder and the knee. And he's the medical director of shoulder surgery at St. Francis Memorial Hospital. He's also opened up an office. Where is that, Dr. Purchase? Up in Corte Madera?
Yeah, Corte Madera, which is about 20 minutes north of San Francisco, just across the Golden Gate Bridge.
Excellent. Okay. And he was trained by some of the very best shoulder and knee surgeons, I have no doubt. And he's a postdoctoral fellowship in sports medicine. And I know he himself is quite fit, which I always appreciate when a doctor kind of does what they talk about. I think that's a good thing. And so for Bay Area patients, or for patients who want to fly in to see this Dr. Purchase, who is a very, what I love about him is he's so present. And I think we all crave that in our doctors, to be present with us in the room and have that kind of the energy about them. So Dr. Purchase, I'm going to hand it over to you. And I think we're going to maybe have Dr. Purchase here till 7 tonight, because we have a lot to cover. Are you going to start with the shoulder, Dr. Purchase? And maybe you'd like to talk about why you even focused on what you're doing.
Yeah, I can start by talking about how I found shoulders. My original interest in orthopedics was really in knee surgery. And my initial residency experience in knees was very, very robust, and I felt very comfortable doing most of the knee surgeries that I currently do today. But I really didn't feel comfortable doing many shoulder surgeries for whatever reason. I just didn't get a huge exposure during my residency. So when I thought about what I wanted to do for a fellowship, I wanted a sports medicine fellowship. I wanted to continue to develop my interest in knees and just kind of round out a basic understanding of shoulders so that I could at least get up to some sort of acceptable level. It's the way life works is sometimes funny. I chose a fellowship, and you choose a fellowship about a year and a half before it starts. Well, 2 weeks before my beginning of my fellowship, the knee attending, the guy that you're supposed to learn more about knees, he left and was replaced by a second shoulder person. So I had a whole year of nothing but shoulders. I humbly would say that I got more than a baseline understanding of shoulders. Doing 12 months of shoulder surgery, I came out of that with a really unique skill set. And then my first job out of training was in a Kaiser health system in Modesto, brand new hospital with tons of patients that just needed services. And I had the wonderful experience of just having more shoulder surgery to do than I could fit in a day. And since I've come back to the Bay Area, I've become more generalized, but it was really more accident, and I really love shoulders. It's just the most complex, one of the most complex joints in the body. It's a huge challenge.
And it's a ball and socket joint, and I'm sure we're going to learn a lot about it. So great. I guess you have some slides that you're going to show us.
Yeah, sure. I'll try to get my slides up, and hopefully, can you see the slides now?
No, not yet. So you'll have to go down to the bottom, and it says share. You'll select the slides.
Thank you for there.
No problem. There you go. And then just select the,
yeah.
There you go. Okay.
All right. Well, so I chose shoulder fractures or proximal humerus fractures for a couple of reasons. First and foremost, I think it's a very common injury, and we'll get into that for in a second. But the other reason, which isn't necessarily apparent on the surface, is that I think this topic highlights a couple of orthopedic trends or some basic themes in orthopedics that, if we have time and interest, I think can serve as a nice jumping off point for further questions or comments. So as I just said, Why would I choose this topic? It's a very common injury. Depending on what study you look at, it's the third most common fracture in the patient population, and probably even more common than that in the patient population of interest here, and the patients that have osteoporosis. And even more relevant, making it even more relevant, is patients with osteoporosis tend to get, not just do they get this injury more commonly, but they tend to get more severe versions of this injury, and we'll get into that as to why in a minute. And then there's a bunch of treatment options, and not just a bunch of treatment options, but a variety of treatment options where on one end you have something simple like a sling for a couple of weeks with early application of physical therapy, all the way down the line to something much more complex like a non-anatomic shoulder replacement. And so we'll try to develop a bit of a rationale about why we might select one treatment option over the other. And it's also quite interesting, at least I think it's quite interesting, that if you had 10 orthopedic surgeons in a room and you started showing x-rays, while there would be some agreement, obviously, about what treatment would be the best treatment, there would also be a fair amount of disagreement. So if you or a friend or a family member ever has a proximal humerus fracture, hopefully you can take some of the information that we're going to talk about today and maybe help yourself or your friend or family member make these decisions. I think any good orthopedic talk starts and ends with anatomy, and there's not going to be a test on any of this, but we're going to just start with some real basic anatomy to shed more light on, at least so that we're all talking the same language. And then we'll finally dive into the treatment options. And we'll talk about the treatment options in three different ways. We'll just list them, we'll talk about the details, and then we'll develop the rationale. And that's really all I really wanted to talk about today. And do it in about 20, 25 minutes, so hopefully leaving lots of time for everybody's questions and comments. So we all know what the shoulder is, but of course, orthopedic surgeons, we can't just say you broke your shoulder, because that doesn't really justify the bill. We got to make it sound smarter than that. So we call it the proximal humerus. Basically the whole arm bone is called the humerus, and the upper part is called the proximal humerus. And it's broken out into many different parts. I'm going to highlight 4 parts. The first one is the ball, or the humeral head. It sits on top of the shaft. And then there are these 2 knuckles of bone called the greater and lesser tuberosity. Obviously, the greater tuberosity is bigger than the lesser tuberosity. These are important because those are the knuckles of bone onto which the rotator cuff tendons attach. This is a very complex slide here, but what the point is, you need a normally functioning rotator cuff for the shoulder to work. Real basically, this muscle on the outside part of the arm is called the deltoid. It is the major power mover of the shoulder. But if all you have is the deltoid firing in isolation, all you get is upward translation of the humerus, right? You get this shrugging motion because muscles only pull. So to get the deltoid, the muscle that does this, to cause rotation, you have to have it counterbalanced by some downward pulling muscles. And that's what 3 of the 4 rotator cuff muscles and tendons do. They provide that counterbalance with a downward pull to allow the deltoid to do its work. So if these are not working or are no longer present in the shoulder, all you get is upward pull of the deltoid. And when you ask a patient who doesn't have a rotator cuff to raise their arm, they can't do this. They do this. They get this shrugging motion. The other reason I bring up those 4 parts is that it is the basis of what's called the near classification. It's the most common way that we group fractures so that patients kind of get an idea of what we're talking about. If you have a fracture line,
Can I interject something real quick here?
Certainly.
So it almost looks like what we're looking at is avulsion fractures. Is that what's happening here? Or are these direct hits, like they're landing on their shoulder? Or some of these, could it be avulsion? Meaning that the tendon or the muscle is yanking the part of the bone off?
That's a great question. The most common way that you see an avulsion fracture is this 2-part with a greater tuberosity is pulled off. And more often than not, that's in a dislocation mechanism. which is relatively unique. So in instability, if you dislocate your shoulder, a patient less than 45 years of age generally just gets a labral tear, and their rotator cuff doesn't have any dysfunction, and that probably represents the greater flexibility of the younger tendon tissue. Patients above the age of 45 tend to get the labral tear as a result of the shoulder.
Labral tear, what a labral tear is for people.
Sure. The labrum is the soft tissue ring that goes around the cup of the shoulder. So that, it's a loosely defined as a ball and socket joint. So that socket or the cup has got a labral soft tissue ring that greatly increases the stability of the shoulder. If the ball were to leave that cup, it tends to tear the labrum on its way out. It doesn't really heal, and that's why once you have one shoulder instability episode, you're at much greater risk of having a second and a third, and is often the reason why we operate on shoulder instability patients. But in that older age group, not older, but the patient age group greater than 45, you might get that labral tear, but the real problem is the rotator cuff has lost some of the flexibility just with normal aging process, and either the tendon rips off the bone or you get this avulsion fracture like you see in this drawing where the tendon remains on the bone but the bone failed. Now the rest of these, the 3 parts and the 4 parts, tend to be falls. So the idea of the near classification scheme is that this is less complex than this, and then as you go up the scale, these become more severe fractures and maybe have greater challenges in treatment. If you look at this and you say, well, wait a second, how do you have? Can you see my cursor on the screen, by the way?
Yeah, I can see it. Perfect.
So the question is, well, how the heck do you have a 1-part fracture, which is kind of an interesting idea. And so inherent in this classification scheme is that if you have a fracture, but the bone has not displaced, it doesn't really qualify as a part. So how do you classify that? And they came up with this funny idea of a 1-part fracture. That's we're not intended to memorize this today. So I just wanted to introduce that classification scheme because I'm going to continue to say, oh, this is a 2-part fracture or a 4-part fracture. And like, if you ever have the unfortunate event of experiencing one of these, you're going to be exposed to this.
Well, the other thing I would say about this, Dr. Purchase, is that I was sure I really love it when somebody has a 1-part where they just have a simple fracture. But if they fall and they fall on the lawn and they haven't really fallen too hard and they end up with that 4-part fracture, those
Right.
folks I'm very concerned about in terms of osteoporosis and the quality of their bone.
Well, I think that's a wonderful segue because that's exactly what this slide is really about. It says, how does a fracture happen? And this is not rocket science. This is orthopedics, right? It happens because of falls. But what you're talking about is the point of this slide. If I I'm mid-40s, I'm about 200 pounds. I'm not by any stretch of the imagination at risk for osteoporosis at this current life stage. So if I were to fall from standing, it's unlikely that I would break my proximal humerus. But we know that this happens all the time. So what's really going on there? It seems like the same kind of mechanism of injury, but a much different injury pattern. And so I'm sure you understand, maybe not. So that bone has a certain inherent strength, right? And if you have an injury that subjects the bone to an amount of energy that is less than the strength of the bone, then nothing really happens to the bone. Yeah, you may have a little bruise, you might have a little strain, but the bone stays intact. But if you have a fall that subjects energy to the bone that exceeds the ability of the bone to withstand it, it's just basically more than the bone can handle, then it breaks. If it's just a little bit more than the bone can handle, then you just get a 1-part or a 2-part, something that's not very displaced. But if the amount of energy that happens at that fall greatly exceeds the strength of the bone, that's when you get these four-part fractures that are widely displaced. But to your point, someone has a ground level fall, there's nothing in that mechanism of injury that would make you think, oh, this person sustained a four-part fracture. Then you get the x-ray and you've got this widely displaced four-part fracture. That's pretty convincing evidence that without any other, at least in my mind, without any other testing modalities, that this person has osteoporosis. I mean, you might want to get other testing modalities just to quantify it, but I think that's a very compelling argument. So anyway, one more view of this four-part fracture. One's a drawing, the other one's an x-ray. There's the shaft, there's our ball or our humeral head and our two tuberosities. Now, what's interesting is I picked this x-ray because you can clearly see all four parts. And that's relatively rare that you can see all four parts as clearly as you can on this x-ray. And maybe this is more appropriate for the question and discussion section. But when you have these complex fracture patterns and you have the sense that you're not fully defining it well enough on a plain x-ray, this is a wonderful application of CT technology. You get a CT scan and you're going to be able to define the injury pattern with much greater detail and reliability.
So can you just also, since you brought up CT scan,
Yeah.
so in this instance, you're going to order CT scan because your most important aspect right now is looking at the bones. But if you were also concerned of muscle tears, you'd be maybe going after an MRI later or actually what? I don't know.
Yeah, no, that's right. So just from a high level view, CT scan looks at bone better, MRI looks at soft tissue better. It all depends on really the plan. If your plan is to maybe not operate, and you're concerned about the status of the soft tissue and of the bone, you get a CT scan and an MRI. That's the best way to answer those two questions. If on the other hand, you're planning on operating, you're going to have your hands and your eyes directly on those things. It's not out of the ordinary to operate on a fracture like this, get in there and find a little rotator cuff tear, and then you can fix it along with fixing the fracture, and you've saved not just the time, but also the money and the simplicity, and you don't have patients running. I mean, if you've got a shoulder fracture, it hurts to lay down and get a CT scan. It's kind of hurts more to get a CT scan and the next day show up to get an MRI. So sometimes keep it simple. All right, so treatment options, just to run through these real quick. Non-operative management is the workhorse for proximal humerus fractures. The vast majority of patients with these kind of fractures, even some of the most complex, the four-parters, are wonderful candidates for non-operative management. If non-operative management isn't going to cut the mustard, the most conservative of the surgical options is open reduction internal fixation. I can't say that more than a couple of times a day, so I often just call it ORIF, and most of my peer group just refer to it as ORIF. That's basically just using plates and screws to hold everything together. More invasive than that is hemiarthroplasty. And you break down that word, it just means half of a replacement. So you're replacing the ball part of the shoulder, presumably the moment before the person fell, before they sustained this fracture. The whole shoulder was normal, including the cup. They fell, now they've got a ball problem, so you don't have to replace the cup. That's why you're only doing half of the shoulder replacement. And for 2 or 3 decades, this was the end of the discussion. About 5 or 10 years ago, we started applying something called the reverse total shoulder replacement in proximal humerus fractures. And we'll get into that a little bit more detail, but it's a non-anatomic shoulder replacement. So the non-operative management, there's nothing fancy here. It's a swing for about 2 or 3 weeks. And then, believe it or not, in that amount of time, the bone starts to get a little sticky, right? There's a soft tissue callus that's already formed, so that the patient can tolerate early attempts at physical therapy right around that time. And as the bone starts to coalesce together, physical therapy can get a little bit more aggressive, range of motion comes back. you know, it all depends, but generally around 8 to 10 weeks. And then once range of motion is fully back, you can start to strengthen people. And it tends to provide very good outcomes in the vast majority of people. Now, depending on displacement, maybe the ultimate outcome or function won't be absolutely positively normal, but it would be satisfactory, meaning the shoulder joint has wonderful range of motion, and we don't tend to use all of the available range of motion in the vast majority of our activities of daily living. Plus, it is surrounded by joints that are wonderfully mobile and are able to compensate for, you know, subtle loss of function like the elbow, the wrist, and the fingers. And then there are also environmental tweaks, right? Like if you normally use the dishes on the top shelf, you just bring them down, or you can rearrange your desk so that you're not reaching out to, you know, the outside very much. So there's lots of ways that we can compensate for subtle dysfunction so that more patients are good candidates for non-operative management. And the ultimate advantage to non-operative treatment is that it's a very low risk proposition. So what happens if you're not a candidate for surgery or for non-operative treatment if you want or / need surgery? I think this is a process that at least I know personally sometimes I undersell in the office. And so I'm going to walk through a thought process, a rationale that every orthopedic surgeon goes through, but we don't often verbalize. So that if you're ever in this situation, you can feel free to ask questions of, well, how did you get to this question? Because we understand how we got to this question. I think we just, as a group, and I know me personally, sometimes don't do this part of my job very well. So these are the two outcomes. We have to decide whether you don't get surgery or whether you need surgery. How do we get there? So we ask ourselves a couple of questions. The first question is, if we do nothing, will the bone heal, right? And the truth of the matter is the vast majority of the times the answer is yes, because Mother Nature's figured this out, right? This is not her first rodeo, but in the rare options that the bone will not heal, unless there's a significant medical contraindication to surgery, then you're gonna recommend surgery for that patient. But like I said, the vast majority of the time, the answer to that question is yes, it will heal. Now,
may I just ask, how long would you maybe wait before you then said, well, this isn't working? Would you be looking at x-rays or something else to determine whether or not maybe it's not going to heal and you might need to do surgery?
I think that's a valid question. In most instances, that is a decision that you're going to try to make right away, because your best opportunity to intervene and get a good outcome with your surgical intervention is within some sort of acute window. And it's different with every kind of fracture, but you have a window of about 2 to 3 weeks where you can intervene and still have it a relatively fresh fracture. And beyond that, all of a sudden you're starting to fight an uphill battle. So for most instances, this is a decision that is best made right away and not necessarily followed. Now, if you make the decision, think, yeah, the bone's going to heal, and you follow it with x-rays, because you are going to follow people both clinically and with x-rays, and it doesn't heal, then it's a different animal. That's called a non-union. And we could talk about non-unions, I think in the discussion period if we want to do that. The only caveat to what I just said in this particular discussion is if you're thinking about doing a reverse shoulder replacement, that is a pretty forgiving surgery as it relates to outcomes. And I'll show you a slide here in a couple of minutes that speaks to this. That is a very successful surgery, whether done acutely or somewhat late. So the benefit to that is if someone has one of these fractures that I'm a little concerned about, but maybe they're not the best surgical candidate or they don't want to have surgery, I feel comfortable pushing the envelope if I'm thinking if they need surgery, it's going to be reversed, because I can get the same outcome if I do it in a week or if I can do it in 6 months. So what's interesting about this question here is, yes, the bone will heal. I think what is hard for a lot of patients to understand, at least unless they ask, is that the presumption is that the bones are going to stay in that position. So if there's a little displacement at the time of that initial x-ray, at least when it comes to proximal humerus fractures, absent surgery, we have no way to go in there and move those bones and have them heal in a better position. So you're basically buying the whatever displacement is at the time of the original x-ray. And you're going to follow them, like I just said, clinically and both radiographically. And so one of the earliest signs of failure of non-operative treatment is if the fracture displacement continues to progress, if it evolves over time and it's getting worse. That's a good sign that you need to change treatment strategies. All right. So if the answer is yes, the bone will heal, we're not done thinking. We have to ask another question. And that next question is, will there be dysfunction if the bone heals in this somewhat non-anatomic way? And I guess inherent in this question, or this question is, will there be dysfunction that the patients would find unacceptable, right? I mean, if you lost 5 degrees of forward elevation, but you have no need for it, then maybe that's an acceptable amount of dysfunction. But if you can't raise your arm to even shoulder height, I think most people would find that to be unacceptable. So will there be dysfunction? And if the answer is no, then there's no reason to go any further. You got your answer. If the answer is yes, you think you're done, but you're not, because there's one more important question, is will surgery improve upon that functional outcome with an acceptable risk-benefit profile? And so sometimes surgery will not make dysfunction better. And there's 2 reasons for that. One, the functional outcome with non-operative treatment is relatively subtle or mild. And surgery sometimes just can't do better than that. For example, the phrase I use in the office is, surgery, when you're making that omelet, you break some eggs, right? So there's scar and there's stiffness. So you might be trading one set of subtle dysfunctional problems for another set of dysfunctional problems, but they all kind of are pretty much the same. They're equivalent. So if surgery is not going to be any better, you're not going to do surgery. And on the other extreme, you might have significant functional deficit with non-operative treatment, but maybe the surgery is not going to be successful either. It's the same kind of outcome. That's a really unfortunate situation. It doesn't happen very often, but sometimes happens. But anyway, if I'm going to anticipate that surgery is not going to make that person better, I'm not going to put them under those risks, and you don't operate. So finally, if you've got dysfunction and you think your surgery is going to make that person better, then you finally get your answer. So in my humble opinion, I think this rationale covers the vast majority of fracture patients and hopefully makes sense.
I think it's great, and I think it's applicable to, to just about any situation, whether it's the hip or, yeah, that's great. Thank you.
Yep. Okay. So we've talked about no surgery, and now we're getting into the surgical options. And so here's an ORIF, and this X-ray down here, this is a 2-part fracture with the ball and the shaft, and both the lesser tuberosity and the greater tuberosity are still on the ball. So this is a 2-part fracture, and the surgeon has gone in there, they made an incision, they've directly manipulated the bone fragments and put them in an anatomic position, and then used this robust plate and screw construct to hold it there long enough for Mother Nature to heal it. And so when you can restore anatomy like this, well, that's going to be a very successful post-operative outcome, as long as you avoid the potential complications, right? So it is surgery, and there are risks of any kind of surgical intervention, but this particular ORIF for this kind of fracture has relatively 2 unique surgical risks. One is osteonecrosis of the humeral head. So you could presume that this person had a normal ball and a wonderful anatomic reconstruction coming out of the operating room, but something happened to this bone, right? It collapsed upon itself, and that's osteonecrosis. And so we know that a certain number of fractures at the time of the injury, the blood supply to that bone had been disrupted. And you're not going to know right away, right? Bone is kind of like a suspension bridge. It has got this inorganic superstructure that is maintained by a whole host of cells, and that's the living tissue. So, I analogize it to the bridge. We have a couple of bridges around here, and if you drive across them every day, you see that there's, an army of people constantly painting it and refilling potholes and stuff like that. So if the blood supply is disrupted, it affects those living cells, and that maintenance isn't happening. And over time, you start to see micro traumas build up, and eventually you see this final macro trauma process, and that's osteonecrosis.
Okay, well, I have a question here too, because
Certainly.
now, osteonecrosis of the jaw is a common, well, excuse me, it's not common. I want people to get clear on that. But
Right.
it is a condition that's associated with prolonged use of bisphosphonates and prolia.
Yeah.
Do you know if there is, or have you seen it, is there an increase? Because again, we're talking about a decrease in blood supply and basically death of the bone in those areas. Is there an increase in either older patients who have this kind of surgery, or do you know, like when you go to your conferences, is there an increase in people who have been on prolonged therapy?
To the best of my knowledge, that if there is a risk, it has not yet been defined. My peer group focus more on fracture characteristics to help us to define risk of osteonecrosis. So
Now, I'm wondering what you see. Like, in other words, do you see it more commonly in older folks? I would think that might just be true anyway. But
yeah, well, so the vast majority of people that have fractures like this that need surgery tend to be older folks because of the osteoporosis issue, first and foremost. Now, the younger folks that get 3- and 4-part fractures, they tend to be that tends to be as a result of high-speed motor vehicle accidents, and so the soft tissue damage done as a result of the high-energy mechanism of injury greatly exceeds the soft tissue injury associated with an osteoporotic patient that fell from standing. So, that's the funny thing about statistics, right? I bet you if you looked at the rate of osteonecrosis in the young versus the old in 4-part fractures, I bet you it'd be relatively equivalent, because you're really talking about 2 different injuries.
interesting.
Right. So that's osteonecrosis of the humeral head. And not only is this a problem, right? This flat pancake of a bone just doesn't articulate as well as the round ball, but you can imagine that screw right there is no longer in bone. That screw is almost certainly cut out, so that when the person is trying very hard to get their range of motion back with physical therapy, that tip of the screw is cutting into the cartilage on the cup. So now they went from having a ball problem, now they have a ball and a cup problem. So this screw cutout thing doesn't always happen with osteonecrosis. It can happen even absent osteonecrosis, but the screw cutout thing is a bad problem. And I'm sure there are some astute viewers out there saying, well, if Dr. Purchase is highlighting this as a wonderful example of how to do the surgery, and he's telling us that the screw cutout is a bad problem, why in the heck would we put our screw tips that close to the joint surface? The answer is that's the best bone. So this bone up in here is relatively not dense, and oftentimes that ball is crunched down and can crunch down that bone, and so when you jack it back up at the time of surgery, what's left is a void. And you can fill it with bone fillers and other things, but they just don't grab the screws quite as well as our native bone. So the best bone to get our screws into tends to be right underneath that joint surface.
So it's more compact bone.
Yes, that's right.
The harder outer cover, yeah.
Right, so we're playing with fire there, so there's a balance. So this is one of the many technical challenges in successfully employing ORIF for proximal humerus fractures. So basically, if you think you can save this humeral head, you're going to do this. If you don't think you can save the humeral head, then you're going to start talking about replacement options. And for several years, it was this hemiarthroplasty. So if you look at this X-ray here, it's a 4-part fracture. This is the ball. This is the shaft. That's a pretty convincing greater tuberosity. I'm not 100% sure where the lesser tuberosity is here. I think it's right there. Again, this would be a great example of, or a case where I'd almost certainly get a CT scan to help me define this fracture. Either way, the surgeon who did this surgery thought that this ball wasn't going to be reconstructible or wouldn't heal, so they replaced it with a metal ball. You anchor it on this metal stem that is cemented into the shaft. And then you have to fix the tuberosities back onto the bone because this is an anatomic shoulder replacement. To get something that represents normal anatomy to work, you need your rotator cuff to work. So in this process, we will use these really heavy sutures. They're actually quite fancy. And you pass them through the bone. The sutures go through the metal stem that is well cemented, pass through each other. You pass sutures through the shaft. I mean, you basically turn it into a nest of these heavy sutures, so that the design is so that when you pull them all together and tie them together, those tuberosities just sandwich around right back where they came from, essentially, and hopefully that they heal. And if you get this ball in the right spot and you get these tuberosities to heal back in the right spot, this is a very successful way to treat these fractures. But if you think that's not going to work, we now, in the last 5 or 10 years, have developed this new option called a reverse total shoulder replacement. And I think I've said this now 3 times. This is not rocket science. This is orthopedics. We call it a reverse because we reverse the ball-cup relationship of the shoulder. So over here in this drawing, this is an anatomic total shoulder replacement. You recognize the metal ball anchored on that metal stem. This is a total shoulder replacement, presumably done for arthritis. So they've got a polyethylene cup on that resurfaces the native cup. Well, in the reverse, you've got this big ball anchored on the cup. And instead of on the ball side, instead of putting a ball there, you've got this cup that's anchored in the stem. And I'll save the long biomechanical discussion. I love that discussion, but it's about 5 or 10 minutes in and of itself. This thing doesn't need a rotator cuff to work. The function of this thing is completely different. It's not a shoulder anymore. It's more like a hip, and it works great without a rotator cuff. All you need is a deltoid for this thing to work.
Wow.
Yeah. Now we'll get into the downsides of it too. So here's a fracture that I honestly have a very hard time trying to identify the parts beyond saying that's clearly the ball. It's probably flipped back towards me, towards the viewer, and there's the shaft. This is probably a comminuted piece of the shaft. I have really no idea where the greater and lesser tuberosities are, and definitely getting a CT scan on this one. But the surgeon did a reverse shoulder replacement. There's our metal ball anchored into the shoulder blade with all these screws. There's our cup. There's a polyethylene liner in this metal tray. Polyethylene is a fancy way of saying plastic, right? So you got the plastic liner in this metal tray that's anchored in a stem that is cemented within the bone. Okay, so those are our options. When we employ these options, I'm sorry. Let's talk a little bit about why we even have the reverse option. Because if the hemiarthroplasty was the best option, we'd only have that because that's what came first. And the downside of the hemiarthroplasty is that there's a bimodal result curve. Now, what the heck does that mean? Now, I have to admit, this is not a graph from any shoulder literature because I couldn't find one that projected well, that looked good. So I just grabbed an image off the internet that I thought was easy to use. So if you had on this axis any measure of patient satisfaction or outcome down here, and up here you had numbers of patients, right? You see two collections of people. You have a good number of people down here in not a great part of the result curve, right? These are people that have had a bad outcome. So you'd say, hey, raise your shoulder, and they go, right? It just doesn't work for them. But then you've got all these people over here that have a wonderful outcome, an outcome that's approaching near normal function. And this all depends on whether those tuberosities healed or not. I'm an analogy person. I love analogies. This is like a home run hitter in baseball, right? This is the person that comes to the plate thinking one thing: I'm going to hit a home run. And as he's going to hit a number of home runs, but he's also going to strike out a fair number of times. Well, so maybe not the kind of result curve that you want for your surgery. So the reverse has got predictably good results, not predictably great results. So same kind of curve, right? If you have some sort of functional outcome down here and numbers of patients, you have very few people with wonderful outcomes. You have very few people with bad outcomes. You got a lot of people right in the middle. So what might right in the middle look like? It's about 120 degrees of forward elevation. So you're getting up to the topmost shelf, but not all the way to the top shelf in your kitchen or your bedroom. You're getting about 20 degrees of external rotation, where normal is about 60 degrees of external rotation. Internal rotation is a funny thing. We often talk about functionally internal rotation as getting behind you. We do a certain number of things behind us, like hygiene, putting on belts, attaching bras. A reverse does not get you back to your bra strap on your back. It gets you to your belt, and it gets to your behind for hygiene. So it's not a perfect outcome. So about 120 degrees of elevation, 20 degrees of external rotation, and back to your belt line. Neither one of them are perfect, but that's their nature, if you will. All right, so now let's talk about a rationale to apply all these treatment options. As I hinted to before, non-operative management, the vast majority of my patients, this is how they are treated, and they get very good outcomes that they're satisfied with an acceptable risk profile. So if they're not a candidate for non-operative management, and you think the humeral head is salvageable, then you can piece it back together with an ORIF, and that's going to give you a good result in a predictable number of patients. If you think they need surgery, but you have some concerns about whether the humeral head is salvageable, then you're going to go into the replacement options. So you're going to do the hemiarthroplasty for that unsalvageable humeral head, and the patient doesn't want/need normal function, and they can't or do not want to tolerate second surgery. I guess what I'm assuming here is the understanding that is if this thing doesn't work, if an anatomic hemiarthroplasty doesn't work, the only other option at that point is to convert this anatomic hemi to a reverse, and you have to have second surgery for that. So if that is something that a patient either couldn't tolerate from a medical perspective or just didn't want to assume that risk, then you wouldn't do this. You would do this. You would do the reverse, right? So that's the unsalvageable humeral head, and they don't want/need normal function, and there is some reason where they wouldn't want to incur that risk of a potential second surgery. I think that's all the comments I had. So hopefully that rationale makes sense, and I'd love to hear some questions, or if you could circle back.
Well, I've got some questions, so I'm going to start with mine, and then we'll go to the other questions. The hardware that we were looking at,
Yes.
how often do you take those screws out?
Mm-hmm.
How often do you, once the shoulder's healed, do you take it out? Are there reasons you don't take it out? Maybe you could.
Well, the biggest reason that we generally do not take it out is that it's relatively deep. It tends not to be symptomatic. Taking out hardware that isn't causing symptoms is not going to result in better symptoms and not going to result in better outcomes, and just subjects people to a risk of additional surgery. Now, we take out that kind of hardware if it didn't work, right? If there was some sort of complication like osteonecrosis. then that hardware has to come out because the patient with that complication gets a reverse shoulder replacement. Oftentimes, hardware this deep, if it becomes symptomatic, it's because it's backed out a little bit. The screws, they're sitting flush with that plate, and they're relatively low profile. Sometimes people will feel it a little bit when they're moving their shoulder around, but usually not because they sit relatively profile. But if that screw starts to back out and starts to become proud, that will catch on soft tissue. If that's happening, I am very concerned that there's a complication going on, and that's the canary in the coal mine. I'm sorry, you had another question.
No, it's okay, because it brings up a lot of questions, because I know all surgeons are not created equal. Some of us are going to end up in the ER. And I know, because I've watched a number of webinars, and not webinars, but YouTube things on conferences with orthopedists kind of complaining about, well, we kind of have to use what we have when we're in the emergency room. They don't necessarily have the top hardware to even use. So are there things that people can do? Because they might not get, well, maybe they do get to you, but some of them are in the ER. Do they call you in, or somebody like you, to do that surgery? Do they have access? And one more thing I just want to add to this, because you mentioned to me the other day about hardware that has threads in it.
Oh, yeah.
Versus hardware that doesn't. I mean, who would even think to ask somebody? And I just know that there's a real range of carefulness.
Right.
So maybe you can kind of speak to all that.
Right. So what you're talking about are fixed construct plate and screw devices. So in a traditional plate and screw, the screw goes into the bone, and the threads are what are, that are cutting through the bone. That's where you're getting the grip for that plate screw construct. You're literally getting what orthopedic surgeons call purchase into the bone, holding the plate onto the bone, and it's that plate that is offering the rigidity to the bone as it heals. In a locking screw construct, there's threads in the screw hole that match the threads on the head of the screw. So not only are you getting purchase within the bone, but that screw is literally threading into the plate, so it becomes one unit. And the rigidity of that locked screw in the locked plate is orders of magnitude higher than a conventional screw.
But do you think, because I hear a lot of cases, in fact, I was dealing with one this week, where the woman had 2 or 3 screws coming out of an ankle surgery.
Yeah.
Is this because perhaps the wrong plate or basically a plate that wasn't as good as what you're describing was used?
I think there are cases where sometimes either the wrong plate was chosen or maybe not put in as thoughtfully. Because the next thought is, well, if locked plates and locked screws are better, why don't we always use them? And the answer is you don't want to make your fractures absolutely rigid. There's this thing called Wolff's Law. Wolff's Law says basically the body makes bone where you need bone. I forget who I'm talking to. You obviously know Wolff's Law.
Yeah, but not everybody does. Not everybody does. Yeah.
Right. So, if you make your fracture construct too rigid, you're basically not getting enough force or stress through the bone itself, and maybe it's not getting the stimulus that it needs to make more bone and to get it to heal. So you don't want to make your fracture constructs absolutely rigid, right? There's that Goldilocks amount. You don't want to make it not rigid enough, but you don't want to make it too rigid.
Yeah, that makes total sense. By the way, can you unshare with me? I forgot to ask you to do that.
Yeah.
You're sharing too much, Dr.
I'm sorry.
There we go. Now they can see us better.
Now, so one of the original questions you asked is how do you behave in such a way to make sure that you're getting the best treatment that you can possibly get? Basically the.
That's a great, yes. And if patients ask the right questions, I think it kind of wakes the doctor up too.
Yeah, that's right. So not every community has access to joint-specific subspecialists. I think one of the wonderful things about the Bay Area is that there are shoulder specialists in every hospital, there are hip specialists in every hospital, there are foot and ankle, you get it. But you don't have to be a joint specialist to be good at, fracture treatment. Now, not every hospital has their best trauma surgeon on call every night. So there is the potential that you don't get the best doctor for your injury just because of the nature of the call schedule. Now, not every fracture this is true. This is particularly true of proximal humerus fractures. Like I said earlier, there's a 2 to 3 week window where you can have surgery done if it's indicated and have the same outcome as if it's done that night. It generally is not an orthopedic surgical emergency. There is an opportunity for a well-informed patient to appropriately advocate for themselves. Is the person on call well considered? Do they have a good reputation? When you meet them, do you click with that person? Do they give you confidence? How do they answer your questions? Do they kind of act defensively and not make no attempt to address your major question? Those kind of things. We have smartphones. We can get on people's websites and see what they say they're good at. And most people, we don't walk on our hands. So if all you did was break your shoulder, most people do not have to be admitted to the hospital that evening.
Good news. A good point.
Right?
Okay.
Get a sling, get some pain medicine. You're going to be no more comfortable in the hospital than you are at home. I guess I'm presuming that you've got social support at home, right? If you live alone, it changes the dynamic totally. But if you can get out of the emergency room and you can start talking to, your primary care physician, might know who's a good doctor in town. You can do a Yelp search. I think Yelp, at least in the Bay Area, if a savvy Yelp user can get insight there. There's lots of different ways that one can deal with this issue.
I want to add one more. Calling physical therapists who deal with post-operative patients can also be helpful. I've done that.
Yeah, other ancillary healthcare providers, and I'll tell you, an untapped resource, if it is available to you, some of the most knowledgeable people about skill level that are able to, sort of appropriately point you in the right direction is an OR nurse.
Excellent. Yeah, that makes a lot of sense.
They see a lot of people operate and they can tell you who's good, who's maybe just okay, who reacts well to challenges in the OR, who doesn't react so positively, that kind of stuff.
Okay, so, I know that we'll probably just stick with the shoulder. I don't think we're going to have time to do knee tonight. And maybe I can twist your arm, but not your shoulder. Come back again to do knee, but, thank you. I mean, you're being very generous with us. The interesting thing is, we see sports people who get horrific injuries, and they're back on the court. They've got the best of everything, and they're not going to, of course, go with this amount of movement. They've got to do those, Warriors. I'm going to get off and watch Warriors tonight. So I mean, they got to get that full thing. So they're going to. I don't know what my question is there, but I guess that the sports top athletes obviously going to get the treatments that are going to help them perform the best.
I think the lessons I've learned, because I had the privilege in my training of covering, Division I athletes and the Philadelphia Flyers and a little bit with the 76ers. And there is an allure to that high level sports medicine. I think I started to get a little disillusioned with it, especially once you get out of collegiate sports. My perception is that a lot of these athletes are treated like thoroughbreds. There's a multi-million-dollar investments, and if they're on the bench because they're injured, they're not returning on that investment. And I'm sure there's lots of coaches and in ownership teams and training staff that try very hard to keep the interest of the athlete in mind. But when you're talking about, and to be quite honest with you, the athletes are participants in this, right? The idea of the athlete is, who cares about the future? I want to be out on the court tomorrow and help my team win. And I think that really short-term focus and the lessons that and the strategies employed with that short-term focus are then hard to take and apply to a more general patient population. So the flip side is when you're really pushing the envelope, you do learn some strategies and lessons that you can apply to the
Sure.
general patient populations. I guess I'm saying you have to be careful.
Okay, so here's a really big one, and I learned a lesson about this and love your input on this one. So new surgeries, like new drugs, they come down the pike, and a lot of the newbie surgeons, I would imagine, get very, enamored with the new surgeries when an old surgery was probably the best. A good example of that, in my own case, is I was going to have surgery on this joint, and I always go to. I would always work with orthopedists, even in my practice, who work with the symphony. So long story short, he was telling me that the newfangled discs that they were putting in this joint had a high failure rate. And the best one was doing the surgery, gathering a little bit of muscle, jamming it in there. I never ended up needing the surgery, but it made me think about it. So I wonder what you think about when some of these new surgeries and we also know the story of early hip replacements. People were getting letters in the mail. Oh, we're recalling your hip. I mean, hello, because of the materials that were used. And you're mentioning, of course, that there's plastic in the shoulder. I don't know if it's BPA free, but maybe you could speak to all this, because I think that's really important.
I think that's one of the hardest decisions to make from sort of from a practice structure point of view, is how does a surgeon responsibly employ new technology and new treatment strategies, because you don't want to wait until it's obvious that that's now the new standard of care, because then you missed an opportunity to treat people with a better method. But you don't necessarily always want to be the earliest adopter either, because you're going to find that you've made a bad choice.
Yeah.
So you just have to really critically evaluate each new technology and for instance, why are you doing it? So I don't do many elbow surgeries anymore, but there's the biceps tendon in the elbow will sometimes rupture, right? The classic example is the 45-year-old male carrying a heavy TV with his buddy, and the other guy falls, and all of a sudden he's holding the whole TV and his biceps pops off. The way I was trained was to use 2 incisions to fix it, right? Use 2 incisions and some suture, and it worked great. Well, about 10 years ago, another company said, well, look, if you use this fancy implant system, you can do it with 1 incision. And isn't that better? And I said, you know what? That is better. Look at what a fancy, slick surgeon I am. I can do with 1 incision what used to take me 2 incisions. And I've done it. I did it for a long time. And then I just had this moment that I was like, why? This is technology overcoming reason. A second incision, isn't a big deal. And if you critically look at that 10 years of data, the single incision did start to look like it had a slightly higher rate of this one complication where you get bone formation where you don't want bone to form. And I said, you know what, I'm going to switch back to my old tried and true 2 incision technique. And so that's the risk of new technology, unfortunately.
And I think that's a great question, because again, patients don't necessarily, the doctors may not say, oh, this is a new surgery, this is what I'm doing. But again, to really be an informed patient, you can say, well, when was this developed? Is this a new surgery? And you want to do it respectfully too. So you don't want to hit the doctor with it. And I'm just saying this, you don't want to hit them with a barrage of questions or here, I've got my list of 20 questions.
Yeah.
You want to keep it to the point, but you just want to say, is this a new surgery? What do is it as successful as you want to be respectful, is what I would say. But I think it's a good question to ask.
And I think if you are an injured patient and you're asking respectful to the point questions, if somebody is responding in a defensive way, look, if you're in the emergency room and it's 3:00 in the morning, maybe that person is just not their best self.
Yeah.
Or maybe maybe that's the first indication that this is not the surgeon for you.
Well, and the other thing too is, we talked about this the other day, you know, you can have someone with a horrible bedside manner, but
Right.
you've read about this doc and you know that as a surgeon, they have a stellar reputation. So again, things to weigh.
Right, exactly.
Okay, so I'm going to share some of the questions. We'll make sure you get out of here on time to pick up your son.
Yeah.
We'll make sure of that. Okay, so some of these we went over. There's the questions. Okay, during surgery, could new fractures occur if bones are not healthy? And what can be done to prevent that?
Well, the unfortunate answer to that question is yes. Certainly new fractures can occur, mostly during the arthroplasty or the replacement surgeries. You're often, you know, I don't want to gross people out, but orthopedic surgery is basically carpentry, but instead of working in wood, I work in bone.
Yeah, no, I think that's a good analogy.
Right. So whenever you have a mallet in your hand and you're banging something into bone, you can definitely cause fractures, and it's more likely to happen in osteoporotic bone. And the answer is you just have to be careful. You have to be aware of who you're operating on, and you know, if there's either a defined situation where there's osteoporosis, or if you're you know, there are multiple red flags, like this is a 75-year-old thin Caucasian female that has a 4-part fracture after a ground level fall. You know, I'm going to treat her like she's got defined osteoporosis, and I'm going to be a little bit more careful. I think what's more interesting is then how do you, if that happens intraoperatively, how do you deal with that? And there's a whole host of options, and it really.
Well, you know, it's interesting, and I mean, I know you don't do that, and also Donna, we won't be talking about supplements and strontium. I know they don't really look at that kind of stuff.
Right.
But in terms of understanding even bone quality, like the tubercular bone score, which is becoming, well, I think I'm a huge fan of it to give us bone quality. So, but there's nothing really that you do ahead of time in terms of osteoporosis patients, as far as I know. Like, you don't check necessarily bone markers or anything like that. And do you talk to them about how long they've been on bisphosphonates, or is that you just don't deal with any of that?
You know, it's funny. I started asking people more and more about bisphosphonates and the duration of treatment. And since, you know, in the last, you know better than me, last 5 or 6 years, when these, you know, these abnormal stress fractures started happening. But in the setting of trauma, my experience is that there's so much going on, and it's really hard to ensure that people are really getting the core message. And we know in a regular office setting, patients only retain 30% of what the doctor says to them. And I've been a patient, you know, I've had family members with significant medical problems, and I'm sitting in the office and I speak the same language as the other doctor, and I walk out of the office and I know I've only caught 30% of what they said. So I'm just keeping it simple. If you've got a fracture, both my questions and my comments are really directed at treating that acute injury setting. And I think a lot of these things, in my opinion, aren't part of my role in that moment. They may become a role later on, or even just enough to say, hey, you should talk to your primary care physician about this, or not, if not your primary care physician, or maybe an endocrinologist or a subspecialist in osteoporosis. Just making sure. You know, the American Academy of Orthopedic Surgeons probably a decade ago had a sort of a public message campaign called Own the Bone. And they're basically saying, hey, orthopedic surgeons, we are often the only people that are involved in a hip fracture patient. And it's our job, if we don't want to treat the osteoporosis or evaluate the osteoporosis, it's our job at least to get the patient into the right hands of somebody who will.
Well, you know, it's interesting because the conference I went to last Friday, they said I can't remember, it's like maybe super low. I don't want to say, I'm thinking 15%, but the amount of doctors that actually do refer them on when they've had a hip fracture, it's really too bad.
I've seen those studies, you're right.
So we're not going to do anything about, we're not going to talk, we're going to do knee another time, But here's the one you and I talked about a little bit from Jenny here. The difference, and I want you did talk about it with me. I'm still not clear really your experience, but the difference between soft bone and brittle bone when you're in there, in the surgery, because doctors refer to it as soft bone. I think a soft bone is, like I said, more like an osteomalacia kind of thing, and brittle bone is like a piece of china. So you could elaborate on that.
Well, so I think I've been thinking about this, and I'm trying to. My experience with soft bone is more when you're working with either broken bone or cut bone, where you actually have, there's the cortical rim, and you have access deeper than the cortical rim. You have this, the honeycomb cancellous bone, and my experience is that when you have access to that intermedullary or metaphyseal cancellous bone, if it's normal, you can take your thumb and press on it, and it's going to resist your pressure. It's not going to crumble. Whereas osteoporotic bone or soft bone just kind of mushes down. It gives you zero resistance. The more I think about that, I'm not so sure my thumb is good enough to know whether it's mushing down or just is very brittle and cracking down. I think it's the same experience, to be quite honest with you. But and that's the best way. Now, if you're talking about brittle bone on that cortical rim, sometimes can be harder. So if you're drilling into bone through the cortical rim going inside, there are times you're like, man, this bone is giving a little bit more resistance to my drill bit, and then the question is why. Yeah.
All right, so let's see some of the questions popping up over here. Okay, so two things that we didn't hit, and I think it would be great to talk about is before we get Connie to rotator cuff tears a little bit more. But I want to talk about frozen shoulder, and in my experience, it's I started seeing a lot of them in women post-menopause, more commonly in women, but my practice was mostly women, and not just one shoulder, but two a lot of times. And one of the things that I've read and or heard talked about at conferences, if you get no treatment in terms of your recovery, because it takes about a year or whatever, it's going to be the same as if you get treatment. And I don't know, what do you think about that?
I think that's a myth. So I think that myth started with Dr. Codman, who was the first person to describe adhesive capsulitis. He of course didn't call it that, but he noted that if we just did nothing for 2 years, patients would come into the office and say, my shoulder feels better. Thank you, doctor, for doing nothing. So I think that is a very doctor-centric way of looking at outcomes. If you start asking people to rate their outcomes, I think it's a much different story. Even if you presume that you can get a patient to a good place with their frozen shoulder within 3 months, and it's the same place that the patient would have got to at 2 years, I think most people would opt for the more active treatment as long as it wasn't, very risky.
Well, I'm glad to hear you think that was a myth. That's kind of was my take on it too. So.
Yeah. And then when you really do dig down into the outcomes, and again, you have to use patient-centric outcomes. There is a difference between more actively treated frozen shoulder and less actively treated frozen shoulder at 2 years. Now the difference is relatively subtle. It's about 10 or 15 degrees of range of motion and a shade better strength. So even if you look in a long range view, I think there is benefit to more active treatment.
Okay, so here's another one. Cortisone shots. Now, so I usually wouldn't recommend more than 2, whether it's bursitis or, certainly there can be circumstances, but as you know, it can result in local bone loss. What are your thoughts on it, and how many do you feel comfortable with? And I guess it depends on the person and how old they are and bone status and
that's right. So it depends on all of those things, and we're starting to realize and define some subtle but real downsides to doing repeated cortisone injections. If you just look at rotator cuff tears, we know, or we're starting to understand, that patients with rotator cuff tears that have had prior cortisone injections to treat that rotator cuff are more likely to have the surgery not heal. So non-healing rates with a rotator cuff repair are low, but not zero. So it depends on the shape and the size of the tear and all that stuff. So if you're saying a baseline 20% risk of non-healing, which is kind of high, but maybe it goes from 20% up to 30%. So that's something to keep in mind. And
to discuss with the doctor. I mean, and
right.
yeah.
I mean, if it's hey, I've had the shoulder problem for 2 years. I know I'm going to have shoulder surgery, but I'm going on vacation. I just don't want to have shoulder pain during that vacation. I think that's a really good way to use a steroid shot if it's the first or second shot the person's ever had. But if it's the fifth or sixth shot, then you say, well, I don't.
Yes,
right.
You're gonna have tissue damage.
Right. The other downside, if someone is going to end up getting a knee or shoulder replacement, and this is very specific to arthritis, we're using cortisone injections for arthritis. We know that patients who have had above a certain number of shots, again, have a greater risk of having an infection at the time of the replacement surgery. Now that risk is about 2% at baseline and goes up to about 3% with multiple cortisone injections. What we don't know is the number of cortisone injections that are acceptable. So some studies show that bump up from 2 to 3% happens around 3 cortisone shots. Other studies have shown numbers as high as 6 or 7. So that discussion is very nuanced, I think.
Okay. Some people are asking, like, what are the treatment for rotator cuff? We're not going to get into that tonight. I'm going to have a physical therapist that is familiar with this, because that in and of itself is a much longer conversation.
Yep.
And one we should have. So I think that's a great question. As well as the active treatment for frozen shoulder. But the same thing is, you want to get physical therapists and or chiropractors. I know a lot of great chiropractors who do great work with this. You want someone who specializes in it or does a lot of them.
Yes.
Works with a lot of these patients. And like I said, a lot of physical therapists who work with post-op patients can be some of the best people to work with. So that's what I would say about that. And I'm in agreement too. I would absolutely work on it. So let me just see if there's a couple more, and then we'll let you go, because you got to go pick up your son. Do bone growth stimulators, do you think they offer any benefit?
Well, that's a very interesting question. We know in problem fractures, and those fractures that either have a history of not healing well, or in the patient that's been defined as not healing well, bone growth stimulators can work.
Okay.
The real question is, who's going to pay for it, right? I mean, in this indemnity model of healthcare delivery, if the benefit is not so obvious that the payor, right, the insurance company, thinks that it's worth it, they're not going to pay for it. And they tend to be expensive. But if you have, the means to pay for it out of pocket, I think that, yeah, they work. Do they work? But the impact isn't going to be equally positive in every fracture model, right? If you got a fracture that's going to heal, there's not a huge benefit.
Okay, so Kat says after a month of physical therapy, she had a really bad fall. And she fractured, she had 2 small tendon tears, a bone spur from before, bursitis, tendonitis, according to the MRI. And then after a month of physical therapy, her PT suggested a second opinion with another orthopedist who uses an ultrasound right in his office to see what's going on with the shoulder. I don't know. That one sounds a little, I don't know. How good is ultrasound diagnosing? Is it really helpful?
Yeah, there's a lot of meat on this bone. So there's many questions in this one question, right? So I think depending on the severity of the soft tissue injury at the time of the fall.
This was some time ago, by the way, like
Okay.
a couple
So
months.
I think once the swelling goes away from the acute trauma, a month or two of physical therapy should be maybe not making the person 100% better, but they should have defined themselves as at least improving with that kind of treatment. And if they're not getting better,
what percentage would you expect?
In one or 2 months, I'd say the vast majority of people, 95% of people,
Whoa.
should be making at least enough progress to make you feel that you're going in the right
direction. I meant what percentage do you want to hear from a patient? So in other words, I'm 10% better, I'm 30% better, I'm 60. What?
So I think at least a 60% improvement.
Okay, that's helpful.
Now, ultrasound can be a very useful diagnostic test, but it has to be in the right hands. There is definitely a skill set that one develops with an ultrasound as far as diagnosis and even interventional treatments. I don't have an ultrasound in my office at the current time, but when I had one, I'll be honest with you, I wasn't as good as the MRI at diagnosing rotator cuff tears. I used it more to help me guide my injections in certain situations. But I just didn't spend the time to develop that skill set. So if this other physician did, it's as good as the MRI. It's not better than the MRI.
Okay. Now, do you or any of your colleagues ever use anabolic bone medications to hasten the healing of a surgery? I know they're doing that with spine surgeries, but I don't know about it in terms of extremities. Well, no, I do know some doctors have used it with extremities, especially with some what do you call it? Sports teams. So I don't know. What do you know about that or feel about it?
We don't use a lot of that in my community. There's I've seen it misused in the HIV population. Lots of individuals with this diagnosis of wasting associated with HIV that were on anabolic medications, and I think there's maybe some hesitancy to use them in my current community.
And what is your opinion about why do people get frozen shoulder? Usually, it more commonly is following some kind of trauma. But I've had people get it out of nowhere. I mean, what is your thinking there?
Well, I think that's the rub with adhesive capsulitis. It is truly idiopathic. It is, to the best of our knowledge, no definable reason. We know it tends to be in middle to slightly older females who have sedentary type jobs and have some sort of metabolic condition, right? So diabetes or hypothyroidism. But beyond those demographics, it speaks to some sort of tissue issue going on. And you even mentioned it, right? You have it in one shoulder. You're not likely to get it again in that same shoulder, but you're much more likely to get it in the other shoulder at some point in the future. So there's something going on there, but no one's, to the best of my knowledge, there aren't people really looking at it. It's not a huge public need, right? I mean, the funding.
No, it's a drag, but it's not. Yeah, I'm going to do some more research on it because I've always believed it has to do with estrogen because there's estrogen receptors in the joints. There's estrogen receptors everywhere, and it's one of the reasons a lot of women in the 2002 study, when they went off of the hormones across the nation they didn't know what they were really doing. A lot of them went back on was because of joint pain.
Yeah. I wonder if that also has something to do, there's this connection with breast cancer, and it seems to be, some of the patients that got it also had the axillary lymph node dissections, but not all of them, and sometimes it wasn't even on the side where the lumpectomy or the mastectomy was done. So I'm not a breast cancer.
And of course, they're on aromatase inhibitors and a lot of other things to decrease it. Well, listen, I'm gonna let you go, Dr. Purchase, and I want to say I really appreciate your willingness to share your time, and this is going to help people who are watching this to be better patients on a lot of levels. And I just want to say how much I appreciate it, and I'm looking forward to nabbing you for a knee.
That sounds fantastic.
Tell us about knees.
Thank you very much for having me. This was a lot of fun.
Okay, and what's your, by the way, is it, how do people connect with you? I don't think you had a, or did you, was your last slide, did that have your contact information?
It had office locations, it had phone numbers, and it had my website on there.
Okay, so just a couple people are saying to you, this has been amazing, Dr. Purchase. Thank you, thank you, thank you, thank you. They're all saying thank you. So, okay, thank you. I'm going to stay on a little bit, but we'll say goodbye to you.
You're welcome. Have a good night.
All right, thank you. Okay, so I'll keep talking for a little bit with everybody. That was amazing. And I think that what I'm realizing is that, you know, I can't do more than one joint at a time, and we're trying to capture some of the, you know, like what to do about frozen shoulder. And I'm glad that you asked that, Connie, tonight, because the proper person to have on is a physical therapist who specializes in this, and I'm going to get that person. And what's been so amazing about doing these interviews is nobody is saying no. I'm just so happy about that. Anyway, you're still all saying thank you, and you're all in the group too. And so anyway, I guess I'm going to sign off not now, but we will have him back on for knees. And I will get a physical therapist, I think fairly soon. That would be another really good one to do. All right. So anyway, yes, all these experts are willing to talk to me and to share their wisdom with you. And at some point, I want to compile some of this stuff because, you know, let's have a list. Let's get a checklist when you're in the ER, what you need to know. If you have a fracture in the spine, what questions do you need to ask before they do anything? You know, I mean, you know, and sometimes you're going to have to be operated on in the emergency room. That's why I do these. So a lot of people think, well, you know, I don't need to know about shoulders. I don't have a problem. Well, when you do, you want to know what you might be able to do about it so that you're in pain. You're not thinking. You have to have a sense about how to deal with this stuff. So anyway, wasn't he a wonderful doctor? Yeah, you know that he would be present in the room with you. All right, everybody. Thank you. I'm going to end the meeting and have a wonderful evening. Good night.